I'm Simon Rule. I'm talking about a presentation I'm about to be giving on acalabrutinib in Waldenstrom's macroglobulinemia. So acalabrutinib is a second-generation BTK inhibitor, follows on from ibrutinib, and this was a trial in around 100 patients, 15 of whom had never been treated for disease. The rest were relapsed refractory patients. In the treatment-naive population, these were elderly patients whose clinical condition was such that they weren't able to receive conventional treatment. The relapsed refractory patients had all relapsed after at least one prior line of therapy. Median prior line of therapy was 2, but almost half of the patients had had 3 or more. So this is a fairly heavily pre-treated group of patients. So the first thing to say is the drug was well tolerated. There was some toxicity, as you expect with BTK inhibitors. Headache is the major side effect one sees with acalabrutinib. It's usually mild, happened in about 40% of patients, and peculiarly it responds to caffeine. So if you drink coffee, the headache goes away, lasts for a few weeks. There were also the other side effects one sees with BTK inhibitors, a bit of diarrhea, but also bruising and bleeding, happened in about 50% of patients in this study. Again, fairly comparable with what one would see with ibrutinib. Neutropenia, perhaps the most significant toxicity, 15 to 17% got significant neutropenia. Again, very similar to what you see with ibrutinib, so all in line with toxicity that one understands. What about efficacy? Well, I've had to write it down here just to remind myself. The overall response rate was 93%, so just about everybody responded. And those responses were very durable. 90% of patients are alive at 2 years, and the progression-free survival at 2 years for the treatment-naive patient was about 90%, and for the relapsed refractory about 80%. So very durable responses. No patient stopped for toxicity, so we were able to continue with the drug despite the minor toxicity that patients experienced. There was some atrial fibrillation seen. For the first time with an acalabrutinib study, patients were included who had a history of atrial fibrillation. That's not been the case in previous studies. And just under 5% developed atrial fibrillation. Again, that's something one sees more frequently with ibrutinib, but just a hint that maybe one sees a bit of that with acalabrutinib as well. So the bottom line was this was a very well tolerated treatment. Just about everybody responded. A quite dramatic response actually. Paraproteins drop quickly, hemoglobin rises quickly, which goes with a very dramatic improvement in quality of life. How does this compare with ibrutinib? Well, it looks fairly similar, is the bottom line. It's very difficult to actually compare unless you do a head-to-head study, and now there is a head-to-head study going on with a different BTK inhibitor plus against ibrutinib. So with time we'll see whether they are truly different or very much the same, but as a treatment for Waldenstrom's, BTK inhibitor is an absolute step change and extraordinarily active drugs.